The clivus is a crucial bony region in the skull base formed by the posterior portion of the sphenoid body, called the basisphenoid, and the basilar part of the occipital bone, known as the basiocciput. This structure serves as an essential anatomical landmark due to its proximity to vital neural and vascular components. Posteriorly, it is related to the posterior cranial fossa. Anteriorly, it connects to the sphenoid sinus and nasopharynx. Superiorly, it is bordered by the sella turcica. Inferiorly, it extends to the foramen magnum, where the spinal cord begins. The clivus is subdivided into three parts. The upper third, located at the sphenoid sinus, and includes the dorsum sellae, making it a key area in neurosurgical procedures targeting pituitary tumors or lesions of the midline skull base. The middle third, which corresponds to the basiocciput and is aligned with the caudal ends of the petrous temporal bones, forming an important transition zone between the clival and cranial base regions. And the lower third, formed by the basiocciput and connects to the nasopharynx. The intracranial surface in this area lies near the medulla oblongata, a critical structure of the brainstem.
Clivus is the central of the skull base and it is formed by the superiorly from the posterior part of the sphenoid bone that is called basisphenoid and inferiorly from the basilar segment of occipital bone that is called basiocciput. The spino-occipital synchondrosis which fuses about 18 years of age forming a single functional unit of this clivus bone. And this clivus anatomically divided into three parts. The upper clivus begins from the posterior aspect of dorsum sellae from posterior clinoid process and end at the level of dural pori of abducens nerve means up to the Dorolo's canal. And this upper clivus is closely associated with the midbrain, upper part of pons, superior cerebellar artery and cranial nerve third and fifth. The middle clivus extends from Dorolo's canal to the level of glossopharyngeal meatus and jugular foramen. It is closely related to middle pons, anterior inferior cerebellar artery, cranial nerve 6, cranial nerve 7th, and cranial nerve 8th. The lower clivus extends from the glossopharyngeal meatus up to the level of foramen magnum and it is related to the posterior inferior cerebellar artery, cranial nerve 9th, 10th, 11th, and 12th. So, important osseous relationship of the clivus include the petrous part of the temporal bone and this petrous part is separated by the petroclival fissure. The internal carotid artery occupies the part of the foramen magnum and some part of the petrous apex, sphenoid bone, and occipital bone. This clivus of Blumenbach is the sloping structure which extends from the dorsum sellae to the foramen magnum, and this is important surgical landmark in endonasal approaches for the accessing the preponderant cistern, anterior brainstem, and other region in proximity.
The internal carotid arteries run laterally along the clivus and are critical considerations during surgical approaches to avoid vascular injury. Additionally, lateral dissections in this area are limited by significant structures, including the jugular foramen, occipital condyles, and hypoglossal canal. The craniovertebral junction is a highly intricate region located between the skull base and the upper cervical spine, specifically behind the nasopharynx. This area can be accessed surgically through an endoscopic transnasal approach, which allows direct visualization of deep-seated structures. Key anatomical components include the vertebral arteries, which ascend through the foramen magnum and form part of the basilar artery, the posterior and superior cerebellar arteries, which supply vital areas of the brainstem and cerebellum, and cranial nerves 3 through 8, which are involved in motor and sensory functions. The endoscopic transnasal approach typically involves lateral displacement of the nasopharyngeal mucosa and the longus capitis muscle to expose the anterior arch of C1 and the odontoid process of C2. This technique enables precise access to challenging tumors or other lesions in the craniovertebral junction while preserving surrounding structures. Several lesions may develop in this region, including both benign and malignant tumors. Chordomas are rare, slow-growing tumors that originate from remnants of the notochord and account for approximately 0.1% of all brain tumors. They typically present as midline lesions in the skull base, infiltrating bone and causing significant surgical challenges due to their recurrence potential. Chondrosarcomas arise from primitive mesenchymal cells or embryonal rests in the cartilage matrix of the cranium. Though also rare, chondrosarcomas are aggressive tumors with a predilection for the skull base and are often located paramedially. Other lesions, such as inflammatory or infectious diseases, may also occur but are less common. Each of these conditions underscores the importance of detailed anatomical knowledge and advanced surgical planning. A comprehensive understanding of the clivus and craniovertebral junction anatomy, as well as their relationships with adjacent structures, is essential for successful surgical outcomes. Modern endoscopic techniques provide enhanced visualization and precision, offering safer approaches to treat lesions in these complex regions.